Hello, my name is Tamaya Robinson. I'm the inpatient nurse practitioner for liver transplant hepatology at Kaiser LAMC. My background is acute care, and I've been in the field. I've been in GI for 4 years, and I've been in hepatology liver transplant for the past 6 years. We're going to talk about liver transplant, introduction to liver transplant. Our objectives today are to discuss basic transplant physiology and biology. We're going to discuss who needs a liver, the types of liver donors, the type of liver transplants, immunosuppressants, survival rates, and we'll go over some transplant terminology and signs and symptoms of acute cellular rejection. So we'll first talk about indications for liver transplant. They include the following: hepatitis. So hepatitis C and hepatitis B hepatitis C is the most common, but you also can see hepatitis B, that would be more acute. Hepatitis C is more chronic. Alcoholic cirrhosis, or even acute alcohol hepatitis. You also have non-alcohol steatohepatitis, which all progress to decompensated cirrhosis. In addition, liver transplantation is a cure for early stage liver cancer. And also there are some programs for certain types of hilar cholangiocarcinomas. Metabolic diseases such as amyloidosis, alpha-1 antitrypsin deficiency, and Wilson's disease. You also have benign liver tumors, hemangiomas, if they're causing decreased quality of life and complications. Liver transplantation would be a cure for that. A hepatic artery thrombosis, biliary strictures, primary biliary cirrhosis, primary sclerosing cirrhosis as well, or cholangitis, sorry. And then also trauma. You can have liver lacerations and contusions that can cause for liver transplantation. So I talked about some of the acute indications. There's also drug-induced liver injury, such as medications. Tylenol is a very common one. Amoxicillin is one of the most common antibiotics. And then you also have street drugs, such as marijuana and ecstasy. I talked about hepatitis B as well, not as common, and acute hepatitis A. Autoimmune hepatitis can be both acute and chronic. So someone that can have an acute on chronic episode, or even just an acute autoimmune hepatitis, and this can be prompted by stopping their medication, non-compliance, versus progression to cirrhosis. So this would also indicate is an indication for liver transplant. So pathophysiology, the liver is one of the most important organs in the body. It does not have any other means, once it fails, to work, such as dialysis for kidneys, ventilators for lungs, or even VADs for heart. It does many functions, such as removes potentially toxic byproducts of certain medications. It produces most of the proteins needed by the body. It metabolizes and breaks down nutrients from food to produce energy. It also produces bile, which is needed for digestion of fat and absorb vitamins A, D, E, and K. It produces most of the substances that are used to regulate blood clotting, and it helps your body fight infection. So some pathophysiology. This is a picture of a healthy liver that has progressed to cirrhosis, which is permanent scarring and damage. And at that point, the only cure would be a liver transplant. Basic structures: you have the liver. It's divided into 8 lobes. It's not pictured on here, but there's 8 lobes that are divided into the liver. You have your bile ducts. You have your hepatic ducts. This will be important later on when I discuss some of the complications following transplant. This is your common bile duct, and it branches off into the hepatic ducts here. Your gallbladder, usually when you're transplanted, you do, or not usually, every time, all transplants, you will not have a gallbladder, but a normal healthy liver has a gallbladder here that connects and stores the bile. So stages of liver disease. Stage 0 is no fibrosis, but you may have some chronic liver disease. Stage 1 is mild fibrosis. Stage 2 is a mild to moderate fibrosis with some walls of scarring. Stage 3 is what we consider the early cirrhosis, and likely you will progress to cirrhosis. So this is what we call bridging fibrosis or scarring that has spread to different parts of the body. And then stage 4, which is cirrhosis, that's severe scarring and cirrhosis. So etiology of liver disease. We'll talk about cirrhosis, which is end-stage liver disease. Cirrhosis is a condition in which the liver is scarred and permanently damaged. Scar tissue replaces healthy liver tissue and prevents the liver from working normally. Scar tissue also partly blocks the flow of blood through your liver. As cirrhosis gets worse, failure ensues. And so some common etiology, I kind of discussed them, and indications for liver transplant would be hepatitis, which is chronic inflammation, and things like NASH, non-alcoholic steatohepatitis, and then you have alcohol steatohepatitis and viral infections and drugs. Abnormal tumor growth, I talked about that. Metabolic or congenital amyloidosis or alpha-1 antitrypsin. And autoimmune etiologies like primary biliary cholangitis, primary sclerosing cholangitis, and which are destruction of bile ducts. And then you also have the progressive disease of the liver and gallbladder characterized by inflammation and scarring of the bile ducts with primary sclerosing cholangitis. So diagnosis of cirrhosis. So tissue diagnosis is the gold standard, but we're not going to do tissue diagnosis, which would be a liver biopsy on every patient with cirrhosis. So other indicators that would give you high suspicion for cirrhosis would be evidence of portal hypertension. So EGD, you would find esophageal or gastric varices. You would have evidence of portal gastric hypertension. CT imaging, you would find nodular liver, splenomegaly. Your labs, your INR and albumin would be, INR would be elevated, albumin would be low. You also have low platelets, thrombocytopenia. And then some of your physical signs of cirrhosis would be jaundice, ascites, clubbing. You also have spider angiomas, which would be seen on the chest. You can have clubbing, gynecomastia. So those are some of the common signs of cirrhosis, physical signs of cirrhosis. So in cirrhosis, you have compensated and decompensated cirrhosis. Compensated cirrhosis is really a low MELD score, which is the model of end-stage liver disease. I'll talk about that later, with minimal signs and symptoms that we just discussed. And then decompensated, higher MELD with portal hypertension, which would be ascites, your esophageal varices, and then your hepatic encephalopathy. So liver transplantation. So you have two types of cure for cirrhosis is liver transplantation. You have two types. You have your well, I don't have it here, but you have a living donor, which would be usually someone that has a lower MELD, someone with mild decompensation, and usually it would be a living donor from a family or relative. And they must meet strict criteria for matching with that particular recipient, the donor, the family member, whoever it is, with the recipient. And then you have your transplant that would be the ortho, the most common transplant, which is where they place the liver in the exact same anatomical place of your old liver. And you have donation after brain death, and you have donation after cardiac death. And you need to be on the transplant list to receive one of these donors. So factors in candidacy for liver transplant. It's very, very involved process. Typically, you have a referral from GI or your primary care physician. They refer to a hepatologist or they present acutely at the hospital. You have your hepatologist, transplant coordinator, psychiatrist, social worker, nutritionist. Severity of malnutrition is really important to identify. Many of these patients, as you guys may know, suffer from severe protein calorie malnutrition, and that's just part of the disease process with wasting. Physical therapy, frailty is a big component in factoring whether or not a patient is a candidate. We'll talk about that later. You have your financial coordinator that makes sure that it's covered under their insurance, and then the support system is also really, really important. They absolutely must have 2 committed caregivers that are committed for 3 to 6 months, and they would have to have the ability to adhere to the complex medical regimen required after transplant. There's many, many meds that are needed for life, but when they're very sick following transplant, they really need help with managing all of those medications. And then the likelihood of surviving the transplant operation, that all plays a part in their nutrition, their physical condition, and other medical things that we look at, such as the heart and lung function. So goals listed for liver transplant patients. So the goals would be to improve balance and strength, increase length of time and distance of gait, improve independence, improve their nutrition, decrease hospital stays, and improve morbidity, mortality post-transplant. The stronger a patient is going into transplant, the better they are coming out. Prehabilitation is really important. When you guys see the patients in the hospital and they're being evaluated for transplant, their physiological reserve is usually decreased because they've had maybe many hospitalizations. So this slide, I apologize, is not showing the way it's supposed to show on my screen. But basically here, you have your red zone, which is the zone of adverse incomes. And if you could imagine these arrows on this side, when you have a low reserve, you go into the hospital, it drops into this zone of adverse outcomes. And that could be death, that could be, more infections while they're in the hospital. And then when they come out of the hospital, they may not have enough reserve to really get into that. And that may not have enough reserve to come out of that and be robust and healthy. So with repeated hospitalizations, it really chips away at their physiological reserve, and they're at higher risk for developing complications prior to transplant and even after transplant. Rehabilitation also includes, I talked about nutrition, I talked about exercise, but really important when the patients are, on the unit, they may have a late evening snack ordered. We want them to have protein of 1.2 to 1.5 grams per kilogram per day. Obviously, they have a salt restriction. Every single cirrhotic patient has a salt restriction, so it's really important to make sure that they're adhering to that. Sometimes family members and friends bring in outside food. Walking is not enough, even though we ask that you walk the patients, but it's extremely important that they're doing muscle strengthening and some sort of exercise. That's difficult in the hospital. When they're outside, we have them engage in classes. In the hospital, we have them engage with physical therapy. But walking is extremely important. So I apologize, some of my slides are mixed up, but what I was talking about before with liver transplantation, living donor, this gives an example of what a living donor transplantation entails. They take out most of a large portion of the right lobe and attach it to the patient's, the recipient's liver. And it's really important that everything matches up because you're already using part of a large portion of the donor's liver to match up with the recipient's structures. The orthotopic liver transplant is the most common, and it's fairly easy. You remove the entire liver and you just put the whole new liver in the same anatomical position. Survival rates are very good. After liver transplantation, there's a 90% survival rate after 1 year, 75% after 5 years, and greater than 50% after 20 years. So following transplant, you guys will see these scars. They'll have the very common chevron incision, which is a bilateral subcostal incision with midline extension towards the xiphoid. Usually the integrity of the abdominal musculature is compromised, so they might look a little bit deformed. Another thing that they might have is some numbing. They may not feel things. It's rare that you will find the T-tubes drains following transplant by the time that they come to 4 North, but sometimes you will see these T-tubes. And these T-tubes are just surgical drains that are in place to keep the bowel ducts open following transplant. So routine lab tests. These are really important. You guys probably see these all the time, and you probably hear us talking about the labs and when they're drawn so that we can follow the troughs. So labs are usually drawn daily at the same time before meds are given, and 7 a.m. is thereabouts, between 6 and 7 a.m. Routine labs are the trough level for anti-rejection medications. That's tacrolimus, cyclosporin, sirolimus, and everolimus. It's rare that you'll see everolimus, and sirolimus is not as commonly used, but tacrolimus and cyclosporin are the trough levels that you'll see the most. We usually do a CMP, CBC, and MAG and FOS. Additional studies may include cholesterol, PTINR, CMV titers, especially if you're trying to figure out why someone has elevated liver enzymes, and hepatitis labs as well. So we're going to talk about transplant medications, and that will include the purpose of the medication, how it's supplied, a dosing route, side effects, and some of the danger signs. Tacrolimus, you'll see it either also as Prograf or in the lab as FK506. That's the original term for it. It's the most important immunosuppressant used to prevent rejection of liver transplant. I would say 99% of patients following transplant initially are on tacrolimus unless they cannot tolerate it for whatever reason. They are usually supplied in 1 milligram, 5 milligram, and half milligram capsules, or in 0.5 milligram suspension. The capsules cannot be crushed. So if a patient has an NG tube or G tube, please do not crush this medication. It needs to be changed to a suspension, or it can be given IV. Dosing and route given orally, it must be given at the same time every day. I mean, obviously in the hospital, you can't give it exactly at the same time, but 8 a.m. and 8 p.m. is really important because we are getting trough levels. So some of the side effects with tacrolimus are tremors, headaches, seizures, very serious altered level of consciousness. That's a very serious side effect and needs to be reported immediately. They can have hyperglycemia, hyperkalemia. They can have hypertension. It causes renal toxicity in a lot of patients. Hypomagnesium. So you'll find that patients are on medications to decrease their potassium, increase their magnesium chronically while they're on a tacrolimus. Some of the danger signs, if too low, then rejection can occur. It can occur as just missing 1 dose, depending on how recent they had their transplant. But missing doses is a big reason. We'll talk about that later. And if it's too high, then toxicity will occur. And some of the signs and symptoms of toxicity are the same side effects, but they're greatly increased. So altered level of consciousness is a really big one. They can have issues within the brain, changes within the brain, and really bad seizures. Those are one of the biggest, most serious signs of toxicity. So other things that you avoid that could increase or cause drug reaction, which could increase the levels in your blood, would be grapefruit, pomegranate, starfruit. And if you must notify the transplant team before adding or subtracting any medication, as it may affect their blood level. So adjusting or making changes to the medications must go through the transplant team first. Sirolimus, it's not as common. It's another primary immunosuppressant. If they're unable to handle the tacrolimus, it's applied in 1 and 2 milligram pills. It's given orally. We do not have an IV form of sirolimus, and also must be given at the same time every day. Usually it's only a 1-day dosing, but it also can cause high blood pressure, acne, rash, anemia, mouth sores, diarrhea, and slow wound healing. It also can increase cholesterol and triglyceride levels. Some of the danger signs, it has a very narrow therapeutic level, or range, I should say. Obviously, if it's too low, rejection can occur, and that's missing 1 dose. I think even more so with sirolimus if they're dependent on that. And if too high, then toxicity will occur. And again, you must avoid grapefruit, pomegranate, and starfruit. PrEP is another very, very common medication. And it's a secondary immunosuppressant. So usually you'll see tacrolimus in conjunction with the CellCept. Typically, we start off at 1,000 milligrams following transplant, and then we taper down, and sometimes off if they've been transplanted a long time ago. But it comes in 250 milligram and 500 milligram capsules. It's given the same time as your primary immunosuppressant. Some of the big side effects with CellCept is nausea, vomiting, diarrhea, anorexia, infection, and one of the biggest things is neutropenia. That is very common. You can get chronic weight loss and absolute neutrophil counts of less than 100. So it can, like I said, cause neutropenia. And it also can cause some GI distress, as mentioned. Cyclosporin, and this is another primary agent if they're, for whatever reason, unable to tolerate tacrolimus. As I mentioned before, it can cause renal toxicity. So sometimes if their kidneys are not doing poorly, they will be put on cyclosporin instead. And that comes in 125 milligram capsules. It cannot be given IV. It's given exactly at the same time, 8 a.m. and 8 p.m. Side effects, really big one with this is enlargement and overgrowth of the gums. And so you can have sores within the mouth because of the overgrowth. Can cause some bleeding and irritation. You can have increased hair growth on the face, arms, and legs. It also can cause elevated blood sugar, but it's not as common as the tacrolimus. Elevated cholesterol levels, and diarrhea as well. Again, if its levels are too low, it can cause rejection, and if it's too high, toxicity can occur. With this, again, you must avoid grapefruit, pomegranate, and starfruit. Prednisone is another common immunosuppressant used in conjunction with the primary, which is tacrolimus or cyclosporin or sirolimus. It's usually given within the first 6 months to a year. After that, they can be even less than that. Some centers wean them off very, very quickly, but some people need it continuously if they have issues with acute cellular rejection, and we'll talk about that later. But it's usually supplied in 5, 10, and 20 milligram tablets. It can cause, just like with any steroid, insomnia, moon phase. Big thing is delayed wound healing, hypertension, hyperglycemia. They may have mood swings and issues with sleep, and fluid and salt retention. Some of the danger signs are they're not a whole lot of major danger signs. It's actually well tolerated. if your side effects are treated. So hyperglycemia, obviously, you have to make sure that if the patient is on prednisone, that they are getting their finger sticks and they're on an insulin sliding scale. And if they are having hypertension, that is addressed. Another medication, something called vangacyclovir, Valsite, which is a prophylactic medication used to prevent CMV infection. That's usually given within the first 6 months to a year, depending on if the donor was positive or negative and the recipient was positive or negative. And so that is usually supplied in 450 milligram pills. It's given orally. So your prophylactic dose would be 450 milligrams daily for renal insufficiency. Regular dosing would be 900 milligrams daily. And then your treatment dose, if you had CMV, which is very common, you will see some of our post-transplant patients develop CMV, and they're going to react differently than someone who's not immunocompromised. Treatment dose is 900 milligrams twice a day for normal renal function, and then 450 milligrams twice a day for renal insufficiency. Some of the big things with Valsite, it's generally well tolerated, but what it can cause is neutropenia. So if they're on Valsite and they're on something Cellcept, right? So sometimes both of those can cause severe neutropenia. So if someone has an active CMV infection, we would stop the Cellcept because that's an immunosuppressant while they're being treated for the infection, and hopefully that neutropenia will improve. Bactrim is another prophylactic that's usually given within the first 6 months of transplant. That's to prevent PCP, and it usually comes in the 800, 160 milligram tablets. It's given orally, generally on Monday, Wednesday, and Friday for patients who have renal insufficiency, and then daily for those who have normal renal function. So if a patient is taking Coumadin and has renal insufficiency, the dose would be half of a tablet daily. So some of the side effects of Bactrim, some people do not tolerate Bactrim very well at all, and we do have Mepron in place of that. A rash, sensitivity to sunlight, stomach irritation. It also can cause neutropenia. So again, sometimes if CMV infection happens very shortly after transplant and they're still on Bactrim, so you'll have Bactrim that will have to be stopped, and they'll start the other medication called Mepron that doesn't cause so much of the neutropenia. Allergic reactions, as stated, and the neutropenia. So overall, immunosuppressant absorption guidelines. If the patient vomits within 1 hour of taking the medication, or if you can see the pills and capsules in the emisses, you have to repeat the dose, because if you don't, then they likely miss that dose. And as we talked about, rejection can happen. If the patient vomits after 1 hour of taking the medication and you don't see any pills or capsules, you don't need to repeat the dose. If the patient cannot keep medications down, so let's say for all day and all day and all afternoon, patient has been vomiting, please let us know, because it's likely that they're not getting their medications, and then we can evaluate and assess whether or not we need to change that medication to something like an IV form. Doses do not need to be skipped for dialysis. So keep the regular dose time. If the patient is going to dialysis and you know that the patient is scheduled for a dose, please send the medication or let the dialysis nurses know. We do have a lot of skipped medications or medications that are given very close to the next dose, because nurses feel that they have to hold the medication for dialysis. Medications cannot be given 4 hours after it is scheduled. So if a medication is scheduled at 8 o'clock and they're for a test or whatever, and they come back and they missed that 8 o'clock and it's 1 o'clock or 2 o'clock, please don't give that medication, and because they have another one due within a few hours. That can cause toxic levels for a period of time, which can cause side effects. blood levels of tacrolimus, sirolimus, and cyclosporin must be troughs. So troughs are the level is drawn 1 hour before it's regularly scheduled. So the blood for the trough must be drawn before the AM dose of the medication. If the patient takes the dose prior to the blood draw, do not proceed with the blood draw. Just let us know, and we can skip that lab for the day. So it's really important that if somehow the lab is late, to not give the medication until the lab is drawn, and then you can get the medication in the morning. Importance of ensuring immunosuppression levels are true troughs. I kind of talked about this already, but the main medications that we're monitoring levels, we don't monitor levels on every immunosuppressant, but tacrolimus, sirolimus, everolimus, and sirolimus. The reason why we want to maintain and monitor trough levels is to make sure that we can catch rejection and change the dosing if the levels are too low. Our dosing is based on trough levels, so we're checking them daily. It's really important that we get true troughs so that we know what's going on, especially if someone is actively dealing with rejection. It's really important that we keep those levels at a level that we know is going to treat the rejection. If the level is, again, if the level is too high or too low, we talked about toxicity and we talked about rejection. Always draw the trough level around, an hour before your AM dose. If it's due at 8, try to make sure lab is drawn at 7. At 6 o'clock, it's fine, and even at 5 o'clock, 2 hours before, it's okay. But we do try to schedule it at 7 a.m. And again, I already talked about not holding it for dialysis. So signs of rejection. Sometimes you may not know that they have rejection other than elevated bilirubin or elevated alk phos. Sometimes they may have fevers. They may have pain over their graft site. Sometimes they have general vague symptoms like fatigue. But more serious, they could become very, very jaundiced, and then they have the dark urine, pruritus, and pale gray stools. So what is rejection? Acute cellular rejection is the consequence of an immune response of the host against the liver graft. It is clinically suspected in patients experiencing, as I stated, some of the elevated liver enzymes such as alk phos, total bilirubin, ALT, or AST. And this is after the exclusion of other causes of graft dysfunction. And you will diagnose this by biopsy. Acute cellular rejection occurs in approximately 25 to 60% of all liver recipients within the first year after transplantation, with the highest risk period within the first 4 to 6 weeks of transplantation. So typically you will not see a patient 4 to 6 weeks following transplant on the unit. Sometimes 6 to 8 weeks you'll see it. So we do get a high number of patients with rejection. Once a diagnosis is made, treatment is fairly straightforward and generally very effective. So this is just a little slide of early causes of acute cellular rejection, which you likely won't see, but it is very important to know. Just in general, if a patient has this history, so it can occur within, usually early acute cellular rejection can occur within the first 30 days, especially after day 8. About 60% of the patients develop acute cellular rejection in the first year, as I stated. Some of the risk factors for early acute cellular rejection are lack of adequate immunosuppression. So initially they're not getting enough. The patient or the recipient is very young at age, so they have a very robust immune system. Higher initial AST level and HLA-DR mismatch. And that's usually during the transplant, during the transplant. And then they have a longer cold ischemic time, meaning that the liver was greater than 8 hours sitting on ice before it was actually warmed up to be placed in the body, in the donor. Older donor age also. and then autoimmune diseases as the original hepatic cause. So patients who have underlying autoimmune hepatitis or even PBC or PSC are at higher risk for developing acute cellular rejection. So clinical picture, you would see an elevated LFTs, but sometimes you won't see, you may see just a slight increase in maybe the alk phos, which can mean anything. And as I stated, liver biopsy is the gold standard. And what you would see in a liver biopsy would be mixed portal inflammation and endotheliitis, eosinophils in the portal tract, and bile duct damage. So some of the most the three most common causes of acute cellular rejection would be missing doses. And sometimes the patient can be very, adamant that they didn't miss a dose, but even if they miss 1 or 2 doses, it can trigger a rejection. Lack of regular blood draws. So, they may be taking their medications on time, but if they're not getting regular blood draws and knowing what their trough levels are, their trough levels could be just chronically running low because they haven't had their levels checked in a while and you don't know. And if their levels are too low, as we stated, that's a risk for rejection. Infections or surgery. So if they have an infection or if they need to go to surgery, they may need to decrease medications temporarily because they do have an infection. And as I stated, like someone with CMV, you may stop one of their immunosuppressants. So it's really a fine balance. You have to make sure that they don't reject. So it's really important if they do have an infection or surgery to really watch those levels to make sure that they don't run the risk of going into acute cellular rejection. So diagnosis and treatment, I did let you know that, the biomarkers, hepatic biochemical markers are what we look at. Taking a good history is very important. Solumedrol is something that we use for pretty much every patient with acute cellular rejection that is moderate, mild, or even, severe, moderate, and even sometimes mild. We might use a lower dose of the IV solumedrol, but typically it's 1 gram 2 or 3 times consecutively. And then we'll switch to typically 60 milligrams orally. We'll taper that every 5 to 7 days. And as I stated before, if a patient is on prednisone, especially with these high doses, you want to make sure that they're getting glucose checks and they're on a sliding scale. And then in addition, let's say a patient is past that 1 year and they're not on any prophylactic medications, they're not on Bactrim, they're not on Valsite, make sure that we have to make sure at that time that now that they're getting this extra dose of immunosuppressants, that they're on these prophylactic medications. And then in addition, we'll have to increase some of the primary immunosuppressants like cyclosporin, Celsep, and tacrolimus. So basic terminology. So MELD sodium is something that I mentioned with the difference between compensated and decompensated cirrhosis. MELD, you'll hear a lot, what is their MELD score? This is a model for end-stage liver disease. It's a score between 6 and 40. It measures mortality risk at 3 months. And this is predominantly what is used to determine whether or not someone, where they are on the list for transplant. So someone with the higher MELD is higher on the list for transplant. So typically if they're in the hospital and you hear that they have a MELD of 40, likely they're going to go bed to bed, or even 30, they're going to go bed to bed to the transplant center to be evaluated or to wait for them to get a transplant. The labs that are used to measure or to calculate the MELD sodium is bilirubin, creatinine, INR, and sodium. The Child-Pugh score is another score that's used to predict surgical mortality. It's originally why it was used. If someone needs to have a surgery and they have liver cirrhosis or liver disease, they'll calculate a Child-Pugh score, which is A, B, or C. It's numbered, and they use bilirubin, albumin, INR, and the assessment of whether or not that patient has ascites or encephalopathy. We talked about OLT, which is orthotopic liver transplant, DVD, which is donation by brain death, and then and donation by cardiac death. The difference between those two, donation by brain death is the most common, and they have less risk factors. You can keep that patient once that patient dies, or once they're brain dead, you can keep the organs perfused, so they have less of that cold ischemic time that we talked about that puts you at risk for acute cellular rejection. So it is the most commonly used. However, there are centers that are using donation by cardiac death because of the demand for liver transplant. Deceased by cardiac death, they do have higher complications like biliary anastomosis or acute cellular rejection, but they still have very similar outcomes in terms of survival rate as donation by brain death. So we talked about anastomotic strictures. Well, I can talk about it now. Basically, when the donor and the recipient's biliary ducts combine, there's an anastomosis, and so we'll get a lot of stricturing if they're mismatched. Sometimes just with putting it back together, you get inflammation and some scarring. So you'll have patients that come in with elevated liver enzymes, and it's not rejection. It's actually because their bile ducts have some stenosis, and they need it to be dilated or a stent placed. Hepatic artery thrombosis. This is where the hepatic artery thrombosis that can happen immediately after surgery. If it does happen immediately after their transplant, they get a new transplant right away. If it happens later on, they're placed on anticoagulants. Sometimes you can do interventions, but the reason why this is really important, and sometimes why these patients who develop hepatic artery thrombosis need a new transplant, is because it supplies about 80% of the bile ducts with perfusion with blood. So when your hepatic artery thrombosed, typically your biliary ducts, they start to die. And then we talked about ACR, which is acute cellular rejection. And that is it. Thank you very much.